Good evening, everyone. Thank you so much for joining us. We are going to give everyone a moment or two to log on, and we'll begin shortly. Okay, everyone. Thank you so much for joining us for the future of female pelvic health, what we know and how we can help. Please submit your questions in the Q&A section, and a link to this recording will be sent out early next week. Our speaker tonight is Dr. Larissa Rodriguez. She earned her bachelor's degree in mathematics from the Massachusetts Institute of Technology in 1989 and her medical degree in 1994 from Stanford University. After completing a urology residency at Stanford, Dr. Rodriguez joined UCLA David Geffen School of Medicine, where she completed a fellowship in female urology, voiding dysfunction, and reconstructive surgery. Dr. Rodriguez is a board-certified urologist with experience in the surgical reconstructive of the pelvic floor conditions. A clinical and basic scientist, Dr. Rodriguez has published more than 100 original studies in peer-reviewed journals. She is the principal investigator of the NIH-sponsored multidisciplinary approach to the study of urologic pelvic pain. It is my pleasure to turn things over to Dr. Rodriguez, who is the chair for the Department of Urology at Weill Cornell Medicine.
Good evening. I first of all want to welcome you and to thank you for joining me. This is a subject very dear to my heart and one that I enjoy presenting. So we're going to talk today about pelvic floor disorders, something that really is very prevalent and affect a lot of women. Pelvic floor disorders affect about 1 out of 4 women. So 24-25% of women at some point in their life will have at least one pelvic floor disorder. And when we talk about pelvic floor disorder, we're talking about particular conditions of the organs that go through the pelvic floor. So the pelvic floor kind of hold things in place in the pelvis, and the urethra, the vagina, and the rectum go through the pelvic floor. So the function of those organs can really be altered when the pelvic floor is not working well. So people can experience pelvic organ prolapse, which is when things fall into the vagina, urinary incontinence or overactive bladder, stress urinary incontinence, and fecal incontinence. And we're going to talk a little bit about these things today. About 11% of women in the US will require surgery for a pelvic floor disorder for one of these conditions. By the year 2050, we expect that there will be a 50% increase in women suffering from pelvic floor disorders, mostly related to the fact that the US population is aging. And these are conditions that are more prevalent or we see more commonly as women age. In 2006, that was a while ago, the estimate for the cost for the treatment of pelvic floor disorders in the US was $412 million. It's a lot higher now, and nobody has done the right study to tell you the exact figure. It really, the women who suffer from these conditions have major detriments to quality of life. Incontinence, as an example, urinary incontinence is the main reason why an elderly woman will lose their independence and will have to leave their place of living to join a nursing home. Incontinence is also a major cause of hip fractures which have incredible morbidity in the elderly. So this is what the pelvic floor looks like if you're looking from the heads down. So it's kind of the bottom of the pelvis. It looks like a bowl, and it's a collection of small muscles that are attached to different ligaments that attach to different bones of the pelvis and the sacrum. And that bowl holds kind of all the pelvic organs in place. And through that ball of muscles, which is depicted here in red, the bladder and urethra have to go through that muscle for you to be able to urinate. The vagina goes through that muscle, as well as babies when they're delivered. So this up here, if you can see my arrow, is the uterus. This is the vagina, goes through that muscle, and the rectum goes through that muscle. So you can see if that muscle is not working correctly, how disorders of defecation, disorders in the vaginal area, as well as disorders of urinary incontinence or continence can be affected. So the risk factors of pelvic floor disorders are listed here. I bolded the ones that are more important in the development of this disorder. So clearly, as we age, there's more people who are affected by these conditions. And vaginal deliveries, in particular, the first child that is born vaginally, inflicts one of the main risks for women developing pelvic floor disorders. Now, the trauma that happens at the time of vaginal delivery is sometimes 20, 30 years before the condition actually manifests itself in symptoms. So there's some trauma that happens to women when they're younger. Many women and their body is able to heal enough that they can compensate. And then as we get older with lack of hormones, after menopause, the tissues get a little more lax, then we start seeing a lot of these conditions manifest around the time of menopause. Obesity or anything that increases abdominal pressure, so it could be chronic cough, chronic bronchitis, obesity can put patients at risk for pelvic floor disorders, diabetes, occupational risk, people who lift a lot of weight in their work. Some neurologic diseases manifest with problems of the pelvic floor. And I put there race because there seems to be a predominance of some symptoms that affect some racial groups more than others. And we don't quite completely understand the reason for that. It's really unrelated to vaginal deliveries and other risk factors. So I'm going to start first talking about urinary incontinence. First of all, it's an extremely common problem in women and as well as men. Men experience it more when they're much older than women. So women start experiencing urinary leakage at a younger age. Its frequency increases with age. Most patients do not mention this problem to their doctors. Most of them don't talk to their friends about it. They're embarrassed. And many people think this is a normal part of aging. And although age is a risk factor for developing urinary incontinence, it's not normal aging. Normal aging would be for you to age healthy without incontinence. So there are definitely things that we can do so that you don't experience this symptom. We call it the hidden condition. And the reason we call it the hidden condition is because people are too embarrassed to talk about it. And many patients self-manage by voting frequently, reducing how much they drink, wearing pads, knowing where every bathroom is, and they don't really seek care for this. Nearly half of patients who end up seeing a doctor for a pelvic floor condition or for incontinence have been symptomatic for more than 3 years before they seek treatment. Of those, about 60% of patients do not seek treatment because they believe there's no effective treatment available and that this is something you have to put up with and live with. And about 73% of patients who do seek treatment are currently not treated appropriately. They're not on medications, so many of the therapies that we know can help. So what are some of these misconceptions and fears that patients express? Some people say, well, this is part of normal aging, is everyday life. It's not severe or frequent enough for me to have or seek treatment. There's nothing or no treatments that exist to help this condition. Treatment will not help me. I am too embarrassed to talk to a doctor about this. I am the only one who suffers from this, so I'm not going to mention it to anybody. Or the contrary, they say, oh, my grandmother had it or my mother experienced it, so I guess I'm experiencing it now too because I'm of a similar age. But what I want to show you is that this is a chronic condition. This is a list or a graph of different chronic conditions that affect the US population. We talked a lot about diabetes, but overactive bladder or urgency incontinence is actually more prevalent than diabetes. It's almost as common as asthma or chronic bronchitis. Yet we don't give it the same importance or the same attention in the medical world than we do these other conditions. I mentioned before, there's a significant impact of being incontinent, especially as we get older. Women and men who are incontinent are 26% higher risk of falling and therefore having a fracture. Usually when they're running to the bathroom at night and they're awakened, they feel they have to urinate and they are going to the bathroom and they might slip or fall. And a hip fracture can be devastating for an elderly patient. It has significant morbidity and mortality. Incontinence and depression is something that we know about, but very little has been done to study this correlation. And it's not that people are depressed because they're incontinent. They just seem to be something in the brain that is bringing these two things happening at the same time. Women who are incontinent are almost twice more likely to suffer from depression than patients without incontinence, regardless of age. So this is a graph. The control, 17% of the US population experience some form of depression. And you can see in yellow, almost 60% of patients who have urgency and urge incontinence have or experience depression. So an incredible increase. I'm putting this not just to tell you that in 1995, again, pretty outdated, the cost of incontinence to the US population was $26 billion, so about $4,000 for each person older than 65. It's a huge amount of money. The reason I'm showing you this is not because of the cost to our economy or our medical system, but more for you to see how, even though I'm trying to let you know how important this is, how little of that cost was in treatment. Only 3% was in treatment cost. Only 1% was spent in diagnostic. The majority, 50%, was consequence cost, meaning urinary tract infections, hospitalization for hip fractures, and the routine costs, which are diaper, pads, things that people have to spend to be able to manage their incontinence, but very little in treatment. So there's a lot of room for us to help a lot of people who suffer from this. And it really has been shown in many, many different research studies that it affects quality of life almost in every aspect of a woman's quality of life. Occupational, meaning in their jobs; emotional, in their homes; their sexual health; their social interactions. There are people who don't go to the movie theater, as an example, because they cannot sit through a movie because they will need to get up and go to the bathroom. Or there might be somebody who doesn't stay in their children's home to take care of their grandchildren because they're afraid of wetting the bed. I mean, these things are really significant for patients and really affect their quality of life. And a lot of people, as mentioned, they find ways to cope. They do what we call defensive voiding, meaning you void before you have an accident. So people are, if they're going to go out, they void before they go out. They void when they get to their destination, really to try to prevent urinary leakage. They know where every toilet is. And I'm sure in this audience, many of you will be shaking your heads about, we call it toilet mapping, but there's some people who really do know from their home to their work where every toilet is, because if they need it, they know where to go. Pads and diapers. A lot of people wearing dark clothes, baggy clothes, so if they do have an accident that goes through their clothing, it will be less noticeable. And many people order on themselves restrict how much they drink so they don't have that much urinary frequency or leakage of urination. So let me talk to you a little bit about what normal voiding is and what it looks like. So on the left is a diagram of a female bladder, which is this triangle structure in blue. In red is the pelvic floor, is the musculature where the urethra go through. The urethra is the tube where you urinate through. These big yellow tubes are the ureters, or the connection between the kidneys and the bladder. So the bladder is really a reservoir. It just holds urine until it's full and you're ready to expulse it. In males, it's a very similar anatomy, except the prostate is between the bladder and the pelvic floor. Excuse me. In a normal cycle, and this is part of a study that we do commonly in patients to try to figure out why they're leaking urine, it's called a urodynamic study. And we can measure the pressures inside the bladder as the bladder fills and patients urinated. So we can look at when the sensations to void are, and the bladder should be flat. The pressure in the bladder should not change at all. It should be like a balloon that you put air and it's not really a lot of tension until somebody has the desire to urinate. And then voluntarily, a patient should be able to initiate voiding by inducing a bladder contraction, which is where this increase in pressure looks like, until they empty their bladder completely, and then the cycle starts over again. This is what a normal urination should look like. What happens when patients have urinary incontinence, especially urge incontinence, is these wiggly lines that are in this diagram in red, is that they can start having bladder contractions that are involuntary. So no longer are you deciding, oh, I'm full, I want to urinate now. The bladder is kind of deciding for you and has a spasm. Think of the bladder as a muscle. And when the bladder has a spasm, it's like it's squeezing. For some people, it's going to make them feel, oh my God, I have to run to go to the bathroom. I'm urgent to go. For some people, the spasm is so strong that their whole bladder might empty. And this is usually a large amount of urine leakage that happens associated with urgency and frequency. There are some patients that have what we call stress urinary incontinence. I'm going to talk a little bit more about the difference between these two things, because I know it's a lot of information to understand very quickly. What happens when people have stress incontinence is that the urethra, the pelvic floor, is weak. When the urethra is weak, it doesn't close very well. So any increases in abdominal pressure, no spasms of the bladder, but anything that increases abdominal pressure, a cough, laughing, lifting, jumping, picking up your grandkids, picking up your children, can lead to leakage of urine because that urethra doesn't close very well. And then there are a lot of people that have a combination of both. They have some urgency and they also have some stress incontinence. So how do we determine which one you have? Because the treatments are very different. A patient history, your description of your symptoms, when do you urinate, when are the symptoms happening? We sometimes, if we don't completely understand, give patients avoiding diarrhea, which is what it sounds like. We give you something where you can collect your urine and measure, and then we give you a piece of paper to do a diary of how often do you urinate, which ones of those urinations were urgent, which ones led to leakage, and you put all that information in about 24 hours just for your physician to have a better idea of when is your problem affecting you and what is inducing it. We review medications. There's some medications that can affect the way people urinate and can really affect not only how the bladder empty, but also how urine is controlled. We always do a urinalysis the first time you come. And the urinalysis is really to rule out a urinary tract infection. People with infections, even if don't know they're infected, can have very similar symptoms. They can leak, they can have frequency of urination, they can have incontinence, and also to make sure you don't have any blood in the urine or anything that would make us worry that there might be something else going on in your bladder or in your urinary tract that we should really look in more detail. But assuming that urinalysis is normal, we usually do a PVR, which stands for post-void residual, meaning we have the patient urinate in the toilet, then they come and we do a quick ultrasound to make sure they're emptying their bladder. Many people who can empty their bladder, and it's not incredibly common in women, more common in men, don't even know they're not emptying their bladder. So you can imagine if you're always holding half a bladder full when you think you're empty, it's going to take you a lot quicker to feel full. So we need to make sure that the symptoms that you're experiencing is not because you're not emptying that bladder. And then we do a physical exam. That physical exam for a urology for this type of problem, besides a general exam, really focuses on feeling the bladder, doing a brief neurologic examination to make sure that the nerves that go to the bladder and the pelvic floor are intact and that this is not related to a neurologic condition, and a pelvic exam in women. In men, it usually involves a rectal exam. We evaluate the pelvic muscles. When we do a pelvic exam, we can evaluate the ability to contract and sustain a contraction. Are they working normally? Are they too tense? You're unable to relax them. Are they painful? And we look for loss of urine with coughing or Valsalva. And we have the patients trained to make sure they don't have prolapse or anything else in the vaginal region that might be affecting the way they urinate or their symptoms. So as I mentioned, I was going to go back a little bit about those type of incontinence, especially if there's anybody in the audience that is suffering from these symptoms. You can start understanding how we think about this and which type of incontinence you might have. And the main two categories are stress incontinence or urge incontinence. Urge incontinence is that it's usually unpredictable. You don't know what happened. You're not doing anything in particular. All of a sudden, you have a leakage of urine. It starts very commonly with having frequency and urgency to urinate. So patients younger, they say, well, they're going more often. Once in a while, they feel like, oh my God, I really have to go. But it's really when they start leaking urine that they come to the doctor. You know, I do see patients if they have a very bad frequency where they cannot they cannot sleep, or they cannot really sit through a movie. But most of the time they come when they start leaking because it's more bothersome. They cannot make it to the bathroom on time. So do you leak on the way to the bathroom? Do you feel like you have to go and yet you don't make it? And some of these patients also have leakage at night. Stress incontinence has nothing to do with stress, by the way. It has nothing to do with you having stress or environmental stress. It's just called stress incontinence, not clear why. It's leakage when there are increases in abdominal pressure and that urethra doesn't close very well. So usually patients say, I leak when I cough, when I laugh, when I do any activity, when I jump. They often have a history of vaginal delivery in their history. They leak usually at night, during the day, and they don't tend to leak at night because at night, unless you're coughing, you're not really increasing the abdominal pressure. And some people have what we call gravitational incontinence, when the urethra is so poor that when they go from sitting to standing, all of a sudden they have a big loss of urine by gravity. So urgency incontinence, that leakage that I said, because you don't quite make it to the bathroom, it's urgent, is leakage with a sense of urgency. And as I mentioned in the original diagram, it's usually because of a bladder contraction. So a bladder spasm, the bladder contracts involuntarily and takes over control of when to urinate. And there are many causes. Most of the time, they're what we call idiopathic, which is a big word in medicine, meaning it's unknown. We don't really know why people get it, but it's definitely related to aging of the bladder, changes of the nerve that go to the bladder and the pelvic floor. Diabetes can increase the risk of having urgent incontinence, obesity, and neurologic diseases. Almost all of them have some aspect where the nerves that go to the bladder might be affected, and people might have this kind of spasms and urgency. Stress incontinence, again, is when people are exercising or doing activity. And usually it's a squirt of urine at the time of the activity. People cough, they squirt a little bit, they stop coughing, and it stops. Unlike urgent incontinence, that could be your whole bladder kind of emptying. And usually it's caused by damage in the muscles, in the nerves, and in the anatomy when the head of the baby is in the vaginal canal. When people are younger, they can compensate for it. But as you get older, that compensation kind of cannot, it loses its effectiveness with lack of hormones and aging, and things get more lax and relaxed. There's some atrophy of the muscles of the urethra, and the urethra loses its tone and its ability to close. So we treat them very different. Usually when you come to see us in the center, we want to know which one bothers you the most. And we try to focus on the one that is affecting your life more first. And then after we get control of that type of leakage, then we will address the other one. In terms of treatment options, both urgency and stress incontinence respond to behavioral therapy, pelvic floor physical therapy to make that pelvic floor stronger. Urgent incontinence, we can give medications, and sometimes we combine treatments, pelvic floor and medication, behavioral therapy, pelvic floor and medication. And if you fail these treatments, there are minimally invasive therapies and surgeries that can be provided to help you with either one of these leakage of urine. Behavioral therapy is usually modifying your symptoms through systemic changes in your behavior or your environment. Some of these modifications include dietary modification, bladder training, where you can train the bladder to go at intervals of time. So we usually tell patients start going every 2 hours. And if you don't have any urgency, do that for 2 weeks, then expand it to 2.5 hours. Do that for 2 or 3 weeks, and then 3 hours. The bladder actually can be trained. There's a lot of behavioral triggers. What we call triggers, if again, for the audience, if you're experiencing any of this, putting the key at the door of your apartment, and all of a sudden you feel urgency and you're like, wait a minute, I was fine. What is with this door and this key? Doing dishes in the kitchen, opening the faucet can give you a trigger that can trigger one of these contractions, and you can have urgency. Pelvic floor physical therapy and some adjunct therapies that we can do with pelvic floor exercises to make those muscles stronger and to teach you ways to inhibit urgency, as well as for older patients, assisted voiding, meaning, and this is really more related to the very elderly, patients that might not have normal sensations and might need to be reminded they have to urinate. And if you don't remind them, they will have a big accident. But if somebody takes them to the bathroom and assists them to get there every couple of hours, they actually can remain dry and not have leakage of urine. So part of this behavior modification program, patients should at home do regular pelvic floor muscle exercises, or what we call Kegels, specified voiding schedule, which is what I explained, of going your normal urination should be every 3 to 4 hours. When we're young, we can hold 8, but that's not normal. It's not healthy either. And some professions are more holders than others, depending what you do. And we can talk about that if anybody's interested. But normal urination, in about 3 or 4 hours, people feel full and they should empty their bladder. There are guidelines of how to control urgency. You know, the idea here is not to become a slave to your bladder, but actually command your bladder. So as part of a good pelvic floor program, people might be telling you, when you feel urgency, make a phone call your friend, sit, don't run, like don't respond to that bladder, and you can slowly retrain that bladder. There are a way of using the muscles to prevent the urine loss, and there's some dietary changes that you can institute. And these are some of those dietary changes. They're really related mostly to things that we know can irritate the bladder and trigger spasms, especially the amount of urine production, like how quickly you make urine. So usually patients, we tell them drink 4 to 6 glasses in 24 hours should be enough and sufficient to stay healthy. There are people who have some medical conditions, they have to drink more than this, or they are on diuretics, so they have to make a lot more urine, a lot harder to manage those patients. If you're getting up a lot at night, try to stop drinking fluids after 6 p.m. or with dinner and not drink before you go to bed, because you're going to mobilize that urine and go at night. But irritants to the bladder include caffeine. Alcohol is a diuretic, it's like a water pill, so it makes you make a lot of urine. Smoking, soda, especially diet sodas. There's something about NutraSweet and some of these dietary supplements that can be really irritating to the bladder. And we always pay attention to your bowel habits. It might be counterintuitive why we care if you're constipated, if what you are coming in is for urinary incontinence, but the nerves that go to the bowel and the bladder come from the same place in the spinal cord, and then they split in the pelvis. So these organs are very much related. There's something actually in research, people have done a lot of studies to document that dysfunction in one of the organs, meaning the bladder, can lead to dysfunction of the bowel, and dysfunction of the bowel can lead to dysfunction of the bladder, what we call communication of these two organs. So if you're constipated, very constipated, your bladder is not going to work very well. So we pay attention to your bowel habits to make sure you're having normal bowel movements so that the bladder has the best chances to be healthy. So the pelvic floor exercises help strengthen the muscles of the pelvic floor, which is this red line here. But if you do them very quickly, there's a reflex that goes to the spinal cord and back to the bladder that can relax the bladder and inhibit one of those contractions that are involuntary. So you can suppress the voiding reflex by doing these exercises in a very quick manner. You do them in a normal manner to just make them stronger. It's sometimes very difficult to isolate that muscle. People think they know how to do Kegels, and you will be surprised. I would say the majority of people don't know how to do them. It's not a contraction of your abdomen. It's not a contraction of your buttocks or your rectum. It's really a contraction of your vaginal muscles. Some people tell patients to learn how to do it. When you're urinating and somebody opens the door and you stop your stream halfway, that you did, that's a pelvic floor contraction, that's a Kegel. You shouldn't be doing Kegels while you're urinating. You can get in a lot of trouble and habits by doing that, but it's a good way to identify the muscle if you're interested in doing this at home. For patients who just can't identify it or they just don't know, there are other adjunct things like biofeedback. It's we put a little probe in the vagina so you can feel, we can measure the contractions that you're doing in a Kegel, and we can show you in a computer so you can actually see if you're contracting normally or you can contract harder or for the contraction to last longer. And rarely for individuals who just can't find that muscle, they just can't, no matter what you do, they just can't isolate it. We can contract the muscle for you with an electrical stimulation in chairs and other ways of doing this, that you can contract the muscle, not only to exercise it for you, but also to teach you where it is. Once it's contracted, a lot of people said, aha, that's where it is, and they learn how to do that exercise. Now, if you have done this kind of more conservative treatment for urge incontinence, they're pharmacologic, they're medications that can be quite effective. For stress incontinence, we don't have any medicines that are effective. So as I said, until now, this kind of behavioral diet, all this can work with either of the two incontinence. After this, they start diverging. So there are medicines that can help with urge incontinence. We usually recommend vaginal estrogen if you're postmenopausal. There's a lot of estrogen receptors in the bladder, in the urethra, and the vagina. And it's just to keep the tissues healthy. It doesn't give you levels in the body. It doesn't help you with hot flashes. It's really very localized estrogen. So you don't have the risk of stroke and heart disease and all those things that we are all afraid of, but that they can still keep the tissues in the vaginal region, the bladder healthy. And it can really help with urgency symptoms and leakage symptoms. And then there are medications that have been designed that you take once a day, some with very, very few side effects to no side effects, and very safe medications that what they do is relax the bladder so you don't have so many spasms, and they can be quite effective. This is an old study, but it showed that when you do behavioral therapy alone, we expect about a 50% improvement. And when we add a drug to it, we see an increase of about 88%. Similarly, we do medicine alone, it's about a 60 or 70% improvement. And when we do both, there's a kind of a synergistic way that they work. So many patients choose to be on both pelvic floor physical therapy or behavioral therapy and a medication. Say you do all that and you're still having symptoms, it's not working, or you cannot take these medications for one reason or another. There are a lot of what we call third-line treatments for urgency incontinence, are all related to modulating the nerves that go to the bladder. Remember, it's those nerves that making those contractions of the bladder so that you have that urgency and that leakage of urine. Some of this include Botox, the same stuff people put in wrinkles. The way it works in the face is that it relaxes the muscles, so the muscles can contract, so you cannot frown on the in your face, and the wrinkles look less prominent. In a similar way, it can relax the muscle of the bladder. We can inject it in the bladder, so you cannot have that many contractions. In the bladder, it lasts longer than in the face. It lasts about 9 months. When it works well, it's like one of those treatments that patients really like it, because you can do it in the office, and once a year they come and get an injection, and that's all they need to do. But there are other devices that if you don't want to be keeping to be retreated, or you're not responding to Botox, or you are not a candidate for Botox, there are other devices, including acupuncture-like treatments that we can do in a nerve, and it's called the tibial nerve. That is a branch of a nerve that goes to the bladder. So they come from the same place in the spinal cord. One branch goes to the leg, another branch goes to the bladder. We can stimulate it in the leg to really get stimulation of the bladder nerve and relax it. And that same device now is recently being FDA approved, that we can implant something that is the size of a nickel that we can put in that area, so you can do it at home. If you do the nerve needles, you have to come to the office, and it's about half an hour once a week for about 10 weeks. If you do the device, you can do the stimulation at home. It's programmable, so that actually stimulation would happen every 4 days or so for you at home. Another way of neuromodulation is to stimulate that nerve, which is the sacral nerve 3, that comes from the sacral root of the lower back. Direct stimulation of the nerve. There's a branch that goes to the bladder, to the levator, and the perineal muscles. This is what forms the pelvic floor. And we can stimulate it with a device that's called an interstim. We can find the nerve in either the right or the left side, and this is done under local anesthesia. And the battery looks like a pacemaker of the heart. It's actually made by the same company, some of them. And it's just like about 2/4 of this device, and this one is even smaller, the one on the right. And we put it right, an electrode that goes near the nerve. We float it near the nerve, and we put this battery near the skin. And this battery can last up to 7 to 10 years. So it's continually stimulating. So you don't have to be worrying about going to the doctor every year to get a Botox injection. It's just once it's stable, you live with it. And when the battery dies, 7 to 10 years later, we just replace the battery and give you a new one. These batteries are always being updated and upgraded. Now you can do MRIs and all kinds of radiologic studies with these devices in your body, which we couldn't do 15 years ago. So there's always an innovation for make them last longer, make them smaller, and more durable. So when we do this type of neuromodulation of the sacral root, for patients that have failed medication, they have failed physical therapy, they have failed everything, we still see 50% of patients reporting great improvement or a complete cure of urgency incontinence. And close to 70% of patients that say they're improving enough that they're happy. So these therapies can be quite effective. About stress incontinence, remember we said we can also do pelvic floor physical therapy, behavior modification, and then after that, if it doesn't work, we don't have drugs, we don't have medications. So things that we can do, one is to inject a material, it's this blue thing that we can inject on both sides to close that urethra. So the idea is to increase the resistance of the urethra, so when you cough, it's less likely for urine to come out. These materials are called bulking agents, are very similar than the agents people use to fill wrinkles. Restylane, or all those materials that you can go to dermatologists to fill the wrinkles, no Botox, but to fill them up. In the face, I think they last about a year. In the urethra, we think they're going to last about 3 or 4 years. These materials always are, new materials are being developed. I actually do some of research in this area, and every couple of years we have a better material that lasts longer and it stays in place. The gold standard for stress incontinence is to do a sling. A sling is a surgery that takes about half an hour to do, where we put a little piece of tape around the urethra to elevate the urethra so the urethra has something to close against when the increases in abdominal pressure. It's very durable. About 80 to 85% of patients will not leak with any activity, and most patients are very happy with that surgery. Now, let's switch from incontinence to prolapse in the rest of the time that we have together. And I want to give enough time for people to ask questions. Pelvic organ prolapse, as I mentioned before, this is a diagram on the left of a normal pelvis of a woman. This is if we cut you in half from head to toe, and we're looking at you from the side. So we're looking at you from the side. The belly button is on the left. The buttocks are on the right. You can see the bone is the spinal cord. This little white structure is your pubic bone. You can touch it if you touch your pelvis. Behind the pubic bone is the bladder, and people urinate through the urethra straight up. The vagina is a potential space that holds in the front the bladder and the urethra. In the very top, it holds the uterus where babies are formed. And in the back, it holds the rectum in place. So you have bowel movements that are straight like that. When people have what we call a cystocele, it's like a hernia. Think of this as hernias of these organs into the vaginal canal. So the bladder can fall down into the vagina. And when people strain, it can even come out even further, even sometimes outside the opening of the vagina. And as you can imagine, when you urinate, now you have to urinate against gravity. The urine in this little pocket, where my arrow is, has to go up and then out of the urethra. So some people have difficulties urinating. They can also have urgency because the bladder is working so hard. The diagram on the right shows a rectocele, or outpouching or a herniation of the rectum into the vagina. And people who have a rectocele usually describe feeling that they stool traps. They're having a bowel movement and then it feels like they trap in some pocket. Sometimes they have to put a finger in the vagina, which we call splinting, to strengthen it, to make it straight so that people can have a bowel movement. And the uterus can also fall down. So when we talk about vaginal prolapse or pelvic organ prolapse, this is what we're talking about. As the uterus falling down into the vaginal canal, the bladder, and the rectum. It could be one of them, it could be two of them, it could be everything. So this is a diagram. If you're lying down, your head is to the right, your feet is to the left of the screen. And this is, I'm sorry, I'm not an artist. This is my depiction of a vagina. In the back of the vagina, if you're lying down, is the rectum. In the very top is the uterus and the cervix. In the front, towards the belly button, is the bladder and the urethra, the little tube you urinate through. So when we talk about a cystocele, is that the bladder has fallen into the vaginal canal. When we talk about uterine descent, is that the uterus are falling into the vaginal canal. And for some people, you can have a rectocele. The rectum is in the vaginal canal, the bladder is into the vaginal canal, and the uterus is into the vaginal canal. This is what an MRI of that original picture I show you. We cut you from the top to down, and we look from the side. This is what an MRI that we do in the pelvic center quite often. It's called a dynamic MRI to really evaluate which organs are moving where. So this here is the pubic bone. Here's the spine and the buttocks. This is a normal pelvis. The bladder is above the pubic bone. The rectum has this kind of a curvature because of the levator. That's where the levators, that's where the pelvic floor is, right where that blue line is. And the vaginal canal usually has kind of a banana shape. It's kind of curved towards the back, and that's a normal MRI. This is what a dynamic MRI will look like for this particular patient. On the left, it's at rest, and then we have the patient strain, and we can look at this almost like a movie. As you can see, the bladder has come down. This particular patient is leaking urine from straining, so we see the urine and urethra. Look at the uterus. The uterus was up here, and now when they strain, it's almost at the mid-vagina. So I'm going to show you the only gross picture that I want to show you. And the only reason I'm doing is that I know some of the people in the audience might be suffering from this. So this is a mass in the vaginal region. This is what bad prolapse looks like. That's it. I'm not going to show you any other gross pictures. On MRI, this is what it will look like. It's the same patient. The bladder is completely out of the vaginal canal. So you can imagine, if this person's going to urinate, this urine has to go up, and then it has to go out the urethra. It's very hard. Some people describe they tilt their bladder, they press, they move forward in the toilet just to have urination, and some of them don't empty completely. So the symptoms, it depends on what organ is falling down, but often there's urinary bowel symptoms, sometimes sexual issues because these things are in the middle of the vaginal canal. Some people describe having pressure in the pelvis, pressure in the vagina, and occasionally low back pain if the prolapse is kind of pulling on the ligaments that are inside the pelvis. When we treat it, we first need to make sure, especially with people with very advanced prolapse, that the urinary tract is normal, that the kidneys can drain into that bladder. The bladder is outside your body, that you don't have any urinary retention, and that the kidneys have no swelling, which is hydronephrosis. Pelvic floor physical therapy, there's some evidence that if you have very mild prolapse inside the vaginal canal, a little bit descent, if you make those muscles very strong, that you might be able to pull it up and postpone how quickly that might fall down into the pelvis. With advanced prolapse, that picture I showed you before, physical therapy is not going to really help. So if patients are having symptoms, we can put a pessary, which is something you put in the vaginal canal just to elevate the organ so you don't have the symptom. It doesn't fix it. It just looks like a diaphragm and it goes in the vaginal canal, or you can have surgery to fix it. So this is what pessaries look like. These are different pessaries, and these are a diagram in the bottom of a ring pessary that was put there to hold the bladder in place, and a Gellhorn pessary that was put there to push the uterus up. When patients decide to manage their prolapse with a pessary, it needs to come out once a month. It needs to be cleaned. It needs to be put back in. If somebody's sexually active, it needs to come out before they have intercourse because it's in the vaginal canal. Patients can learn how to take it out, how to clean it, how to put it back in. Otherwise, your doctor would do it for you. So this brings me back to the Female Pelvic Health Center, which is, we're very excited to be launching at NYP and Weill Cornell. As you saw from the talk, when people have pelvic floor disorders, they can have problems in the bowel, in the vagina, sexual dysfunction, urinary incontinence. So there's a need to have multiple specialists involved to provide the best care that we can for patients. So the Female Pelvic Health Center at Weill Cornell and NYP includes urologists, people like me who are also urogynecologists and experts in female pelvic medicine and reconstructive surgery, gynecologists with a very similar expertise. We are going to include pelvic floor physical therapy within the center because, as you saw, such a big role for conservative management with pelvic floor physical therapy. Colorectal surgery, because there are some abnormalities that I did not talk about today that involve prolapse of the rectum in different places where we work closely with our colorectal surgeons, or patients that have such bad dysmotility that they cannot have bowel movements or difficulty with bowel movement, or fecal incontinence with colorectal surgery can be very helpful. Rehabilitation services, these are doctors, physicians that are experts in muscle-related conditions. So they are also going to be, they're also part of the center to help with the pelvic floor muscles and work closely to our physical therapist, but abnormalities of the pelvic floor muscles, and gastroenterologists that really can help us manage fecal incontinence as well as constipation and bowel issues, IBS, and other conditions that can be related to some urinary conditions as well. We have an active fellowship. Currently, I'm the director of the fellowship. We are training the next leaders in pelvic health, and we're training both gynecologists and urologists, a combined fellowship. We have 3 fellows every year, and they spend, depending on their specialty, 2 to 3 years with us. They do research, they take care of patients, and to become the next leaders in our field. So the mission of the center is to offer differentiated pelvic health services tailored to address the unique needs of women in all stages of life. And our mission is really to change the way we provide care for women and in pelvic medicine, offering a multidisciplinary approach to address the physical and psychosocial well-being of diverse patients through innovative care delivery models, continued quest for discovery, and advancing education, which is where I talked to you about the fellowship. These are some of the areas that we currently are doing research, cutting edge research in our center, including looking at disparities of pelvic floor disorders, why some communities develop this more than others, why some seek care more than others, why overactive bladder urgency incontinence is more common in African-American women, while prolapse might be more common in white women. There are differences that we don't completely understand why. I am particularly very interested in how stress, environmental stress, when we're stressed out, different than stress incontinence, influence lower urinary tract symptoms. So I have an active laboratory in basic science, and we look how stress is really inducing frequency of urination and even bladder pain, and how what we discover in the laboratory might help us develop new therapies for humans, for people. I'm really interested also in how the brain modulates the pelvic floor. So we have made a lot of discoveries in some of our research of areas of the brain that seem to be very, very connected to the pelvic floor. So that for some patients, in addition of doing pelvic floor, in the future, we might be able to put a magnet and stimulate areas of the brain to really rehabilitate some of that pelvic floor and help them with their symptoms. We have currently 3 active clinical trials. One is looking at that coin device for overactive bladder. One is looking at new medications that are being developed for bladder pain conditions. And one is looking at the stimulation of the brain. We have an active laboratory where we look at preclinical models to really try to make discovery of new therapies. So really the idea is to provide comprehensive care. This is kind of where we are, or which is the development of the center, where we treat these conditions: pelvic pain, pain with intercourse or dyspareunia, pelvic organ prolapse, pregnancy-related pain and urinary issues, urinary and bowel incontinence, urgency, frequency, recurrent UTIs, fistulas. In the future, as we grow, we really want to integrate dietary, a dietitian, life coaches, how really these things are affecting other aspects of a woman's life. Provide virtual classes, this is one of them, but hopefully provide more virtual classes and education for our patients, our communities as well. And we also would like to, as I mentioned, we're going to have physical therapists to integrate their advanced training into how we can make the pelvic floor woman stronger and better, so to treat some of these conditions, to really develop a unique approach of integrating therapies that address the physical, mental well-being with exceptional outcomes, and to really integrate our cutting-edge research and develop new therapies to continue to innovate and discover. I want to thank you. I want to thank you for listening to the talk. I'm going to take questions, and I wanted to put some information on how you can reach us and how you can make appointments if you want to see us in the center. I had, Elisa, unless you have something in mind, I was going to answer we had some questions that were sent in before the talk, and I want to address some of them, and then we can take additional questions if we have time. Is that okay, Elisa?
That's perfect, Dr. Rodriguez. Yes, we have a lot here, but I think there may be some overlap with some of the questions that were already sent in. So yes, let's start with those.
So one of them was, somebody was asking about a urethral carbuncle. A urethral carbuncle, this is a diagram of the vagina, and this little thing in the middle is where you urinate through, is the urethral opening. A urethral carbuncle is like the mucosa inside the urethra protrudes out, and you can see it as a beefy red thing. It's actually a very benign, very common thing that happens when there's lack of estrogen. And if you have symptoms of it, most patients have it, we see them and they don't even know they have it. We don't always mention it because it's so common in postmenopausal women as they get older. But if it becomes bothersome, and what it bothersome is that if it's rubbing against your underwear and it bleeds, or it gives you any discomfort, applying estrogen to that carbuncle makes them shrink significantly. We seldom have to operate on them. So that was one of the questions. There was another question. Somebody asked if there were alternatives to estrogen replacement therapy. So again, everything I talked about today is not estrogen replacement. I'm not talking about systemic estrogen. I'm talking about estrogen that you apply in the vaginal region. It's very localized, and you don't have the side effects or the risks that you can get from having estrogen all over your body. There is some data that may be vaginal lasers for people who cannot use estrogen at all. There are breast cancer survivors of cancers that are very sensitive to estrogen, and their oncologists don't want them to be on estrogen for any particular reason that laser therapies might be able to thicken that vaginal epithelium to help with urinary symptoms and etc. And infections. There's not great data showing that lasers are effective against urinary incontinence. Somebody asked about having a total abdominal hysterectomy and developing urinary tract urgency afterwards. So we know that having a abdominal hysterectomy long-term, many years out, increases the risk of experiencing urinary incontinence. We learned a lot of this from the nurses study, where nurses many years ago, where we learned a lot of the hormonal studies too, having follow a cohort of people and see them kind of age through their lifespan. And those that were that underwent a hysterectomy for whatever reason had a slightly higher chance of having urinary incontinence. We think it's likely secondary to nerve damage at the time of hysterectomy. So especially if you have a total abdominal hysterectomy for cancer, the plane is very wide and very broad. So they take some of the lymph nodes as well, so that there might be some damage to the nerves that go to the bladder, so that long-term patients might develop some urgency and kind of bladder dysfunction that is treatable, just like we mentioned before of the urgency, but that might be slightly chance of developing that after hysterectomy. And those are the only questions I had, Elisa, from that were sent before.
No problem. We have a lot of questions here, so we'll do our best to get to as many as we can. Someone is asking, what steps do you take to protect the clitoris during surgeries?
So our surgeries are in the vaginal canal. So it's really not, this is the clitoris, we operate down here. We protect the urethra too. Yeah, and the urethra is in the way. We don't want to injure that too. We're really kind of in the vagina for most of our surgeries, or we do our surgeries robotically from the abdomen. So we're quite far from the clitoris.
Someone else is asking, is prolapse hereditary, and what are some of the early signs of this condition?
So yes, so the majority of prolapse is not hereditary, but there is definitely a genetic predisposition from developing prolapse. There are actually some families where it seems to be almost autosomal dominant, meaning that every female member develops prolapse. They tend to develop it younger, but there's definitely something related to collagen deposition. Patients who have collagen abnormalities like Ehlers-Danlos can get prolapse very young in life. And in those families that have those genetic predisposition, men get hernias and women get prolapse. It's very interesting. So there's definitely a genetic component, but we haven't sorted out completely to develop any genetic gene-based therapies to treat it.
Then someone else is asking, what is nocturna, and is there help for that?
Yeah, so nocturia is a very miserable symptom, and it's a very difficult symptom to treat. So nocturia means getting up at night to urinate. Now, by definition, it cannot be that you can't sleep, so you go to the bathroom many times. You have to be asleep, and the bladder has to wake you up. So when we measure nocturia, it's from the moment you fell asleep to the moment you get up in the morning. How many times did that bladder wake you up? And it's multifactorial, which is why it's so difficult to treat. Some of it is the same that I discussed here, is bladder spasms. It's a version of what happens during the day with those bladder spasms and that urgency that it continues happening at night because the bladder doesn't know if it's daytime or nighttime. But there are other components when people have nocturia. People with sleep apnea can have some secretions of hormones that make them make more urine at night. As patients get older, and I mean significant older, the kidneys don't concentrate as well as night, so they actually can make more urine at night than they do during the day. People who have swelling on the legs, or what we call edema, at night when they're lying flat, all that fluid is going to be mobilized and they're going to make more urine. So there are a lot of factors with nocturia that we have to look at. And people who have congestive heart failure, where they lying down, they cannot process the fluid as well, and they will have more nocturia as well. So it's multifactorial and really hard to treat, or tricky to treat. For the bladder component of it, we treat it very similar to the urgent incontinence that we talked about.
Someone else is saying that you listed diabetes as a risk factor. Are there different levels of risk for those who are well controlled versus less well controlled?
We don't know a lot about diabetes. So the basic answer would be yes. The better control your diabetes is, the better all the complications of diabetes are. Diabetes can affect the bladder in many ways. It starts by people having kind of overactive bladder symptoms, kind of urgency of urination. But just like diabetics that are poorly controlled can get numbing in their legs, and they can get numbness in their legs, you can get numbness in the bladder. So sometimes diabetics that have more advanced disease stop feeling like they have to go to the bathroom. And that doesn't bring them to the hospital or a doctor. They just go less often. They're not bothered by it. They can hold 4, 5, 6 hours. And that happens first. And what we call terminal bladder of a diabetic that is poorly controlled is where the bladder pretty much stops working. Patients can go in retention because the bladder loses its ability to contract. And that really we see on type 1 diabetics that are poorly controlled, or type 2 diabetics that are very poorly controlled. But the overactive bladder symptom, we can see even in patients that are adequately controlled.
We're getting a lot of questions about Kegels, and people are asking, how long should they hold the Kegel for, and how often should they be doing them?
So I like my patients to see a pelvic floor physical therapist. The reason being is that one thing is for me to tell you, go to the gym and come back in 3 months and lose some weight while you're at it. Another thing is for me to give you a personal trainer. So I think about physical therapy as a personal training. And the reason that I'm telling you that is that they will do an assessment that lasts about an hour to try to develop exercise program for you to take at home, and it's individualized. So it's different for every patient. But when you look at Kegels in general, it's about 10 repetitions that you can do about 6 to 8 times a day. So this kind of 10 repetitions, and you try to hold it for a few seconds. So you contract 1, 2, contract 1, 2, do it 10 times, and then do it a few times a day.
A couple of people are also saying that during the day, they're able to hold their urine for longer, but then when they sleep, they're actually having to urinate more frequently.
Right. For the nocturia that we were talking about, and all those factors that I mentioned can be a factor. Every person is different.
Let me just see here. Someone else is saying that when you were discussing neuromodulations, they're asking if this is a common treatment. They live out of state and they feel like it's less available in other parts of the country.
In specialist hands is fairly common, but it has to be somebody who's a specialist in pelvic floor disorders, either somebody with a special training in urogynecology, or it's less common in gynecologists that do urogynecology, more common in urologists that do urogynecologists. So I am a little biased because in my world it's fairly common, but I can see where the patient is talking about is not as generalized a treatment as others are, for sure.
We have another question of, do you treat interstitial cystitis in the clinic?
Yes.
Okay. The machine that you showed with the pads on the ankle, is that a surgical procedure or a non-invasive procedure?
So that is a form of neuromodulation of the tibial nerve. The non-invasive is a needle that is put, you have to come to the clinic. A needle is put in the ankle and you're stimulated for half an hour, and you do it once a week for 10 weeks. It's called peripheral tibial nerve stimulation. Now, because of the inconvenience of having to go to the office, there's a couple of companies that are developing devices that you can put under the skin, which is you do it in the office, but it's a small cut in the skin to put these devices. That's one of the clinical trials that we are conducting to see if patients can have this device for 5, 6 years and have continuous stimulation instead of having these bouts of 10 treatments, 10 weeks, and then maintenance of once every 4 months, 1 treatment, or 1 every 5 months. But the therapy does exist, and we have it in the center where there's no cutting of the skin, and it's the traditional needle and acupuncture with an electrical stimulation to that nerve, half an hour, once a week for 10 weeks.
Someone else is saying that they have complex regional pain syndrome and a lot of nerve pain in the perineum area. Is there any, treatment for this chronic condition?
That is really tricky. Complex regional pain syndrome is a very systemic problem. Even when it starts in one location, sometimes it spreads. So it's hard to answer that question in this forum because it depends if it's really localized only to the perineum or it's really more of a systemic problem, or a problem with the nerves in the whole body and chronic pain in the whole body.
Another person is asking, is there any science behind the more UTIs you have, the more susceptible you are to have them in the future? And will they have a buildup of scar tissue? So
usually not. UTIs are very localized to the bladder. And I don't know exactly what the question is going to, but we see this kind of modal, for people who are prone to have them, we usually see them in late adolescence, early adulthood when they become sexually active. And then for the majority of adult life, they go away. And then around the time of menopause, we see another kind of bout of these urinary tract infections that with vaginal estrogen and some treatments, we can get most patients normalized. You don't necessarily get bladder scar tissue from UTIs if they are treated and well controlled.
Someone else is asking, what effect does multiple C-sections have on the bladder and incontinence?
It shouldn't have any unless there was an injury to the bladder at the time of a C-section. And you would know that if that happened, but for the majority, 99.9% of women who have C-section, the bladder is not injured. It's just moved out of the way. Actually, when the uterus grows, it grows kind of almost in front of the bladder so they can get to the baby without touching the bladder. So just having multiple C-sections should not affect your bladder function. It's actually protective. So people who have C-sections that are scheduled, where they haven't gone into labor, they have less rates of prolapse and incontinence than people who've had vaginal deliveries.
For immediate postpartum incontinence, when should someone reach out for treatment? They were told to typically wait 6 weeks to see if it resolves on its own.
We usually say a year. Things are going to continue changing for a year. You can reach out for treatment, but most people are not going to give you any, and they shouldn't give you any aggressive treatment because most women, these symptoms resolve within a year. But for some women, it takes that long for the symptoms of urinary incontinence to resolve. So we usually, if the patient comes, we see them, we assess them. If they're emptying their bladder, everything else, we usually tell them to wait it out. Physical therapy could be helpful, but nothing more invasive than that.
Someone else is saying that they had a full hysterectomy and that they were left with many abdominal adhesions. Do they have to have the adhesions removed in order to improve incontinence?
That is really hard to tell. I don't know what to tell you because we have no way of imaging adhesions. Adhesions, we only know they're there once somebody goes inside the abdomen to look at them. And it depends what is being adhered to what, if it's going to affect incontinence or not.
So I know that we're over and there's still a ton of questions. A lot of you are asking very specific questions that would be appropriate only for you. My best suggestion is to please call the phone number, make an appointment. Some of them are very hard to answer without additional information. So I think it would be best to schedule an appointment and see the different ways that we can help with everything. I'm just trying to see if there's any other quick questions that we can get to. Oh, do Kegels help men too?
They do, so it depends. For overactive bladder, they do. I'm sorry, let me move this picture. So let me do that. How about that? For stress incontinence, the majority of men who develop stress urinary incontinence actually from surgery. They develop it after a radical prostatectomy for prostate cancer. And Kegels in that population can help men regain continence sooner, but overall doesn't change who's going to be incontinent or who's going to be dry. So it just helps them regain continence earlier, those that are going to regain continence, if that makes sense, but it doesn't change the overall trajectory of their leakage after a radical prostatectomy, if that's what you're asking about.
I believe so. I didn't have any more context with some of it. So I do apologize that we couldn't get to everyone's questions. There's so many here. Again, like I said, I would encourage you, if you are unsure, you have additional questions, please feel free to schedule an appointment. That would be your best way to go about that. The center is open and we're seeing patients, and we will be sending out a recording probably sometime next week. Dr. Rodriguez, thank you so very much for your time tonight. This was so informative and so helpful. We've gotten so much positive feedback. We've had a few of your patients on here just mentioning that you performed surgery on them and their life has been drastically improved from that. So kudos to you. Thank you.
You. It's really, for me, this is, as I said, very important and meaningful. This is something very dear to my life, to my heart, and something I love doing. I wish I could see all of you and that we could have more one-on-one conversation, but it's obviously very difficult to do in this format. But thank you so much for joining, and I hope that for many of you, some of your questions were answered.
Thank you so much, everyone. Have a wonderful evening.